The results did show that the diet was very different, and it was very. And I don't know. I hope Prof. Olatushe can answer, because I don't know the exact, whether it was heavy metals or what it was that they found. But even in a small number, it was enough to actually suggest that they should look at a case control or a further study to validate the linkage.
Thank you for clarifying that. I was a little concerned. Anyhow, so let's go. If Prof. Letitia, are you on the call? If you're on the call, I would love to hear what you have to say.
Yes, I'm on the call.
Good,
Can you hear me, please?
Yes, nice. We
Yes.
hear you.
Yeah, like I said, I'm cutting in and out. One question that I had is that if not fit, what can we use in low middle income country?
Yes.
Is that one of the questions for me?
Yes, sir.
Yeah, I think if not fit, it has to be something that works in our environment and that the system can also be able to deploy. FIT is not working in our environment because of the false negative rates, false positivity rates that it has, just like Dr. Knapp said. But the question is that, is it going to be the similar situation in Barbados? That has to be sorted out. Will FIT work? Will it not work in Barbados compared to Nigeria? That's one thing I feel that is a challenge that the researchers and the scientists in Barbados need to answer. Which is the best instrument to use? So if we are using, we need to try that first before we can discard it. Because we have said it's not working in Nigeria does not mean it is not going to work in Barbados. Let's get that clear. So we need to do some studies to be able to select what is the best. Assuming we got to a scenario which FIT is not the best, just like we found. One of the things that we identify from our colonoscopy series is that most of our patients have symptoms that are not presenting to the hospitals early. And because they are not presenting, majority of them are coming with late disease. So our target is to see how can we catch those patients that are presenting with stage 4 as early as possible. And because we know that 70% of our diseases is on the left side, a majority of them present with rectal bleeding. So we deploy using rectal bleeding as a surrogate for identifying colorectal cancer. We did an initial pilot performing colonoscopy for about 350 individuals that have rectal bleeding. And in those cohorts, about 20% of them actually had colorectal cancer. We took this to a larger community and we did publicity and a lot of social media advocacy in 2 local governments in Nigeria. We just concluded that study and we are trying to write it up. In that new cohort that we deploy using some symptoms, rectal bleeding, rectal anal pain and other symptoms, we detected about 4 colorectal cancers in that community. In that community, we also identified patients with familial adenomatous polyposis, about 2 of them that have familial adenomatous polyposis, and they've been in the community for a while. We saw those patients at age of 40. You know that patients with familial adenomatous polyposis ideally should have been identified much, much earlier. Now we are conducting screening for the family of those individuals that we identified. Mm-hmm. So symptoms can also be deployed using the symptoms. I don't know what the colonoscopy series look like in Barbados. So if you can look at the series, what are especially those that are having symptomatic that are having symptoms. Which of the symptoms can work and can be used as a surrogate to identify patients that have colorectal cancer. We think rectal bleeding is very useful in our environment, and we are deploying it at a larger scale to be able to identify people early and to be able to identify those that have polyp, advanced polyp, and colorectal cancer, and to be able to treat them. So, FIT, we have to be sure it will work or it will not work. Symptoms is another thing that can be deployed. though not ready for the prime time. Urine-based test is something that we have done, we are working very hard on. It shows to be promising because it has a high sensitivity and specificity to detect colorectal cancer. But currently we are hoping to deploy that in in 3 other African countries to compare the effectiveness of this. If that works, that may be another thing that we have to use. So we need to be innovative and look for something that will work best in our community rather than adopting guidelines that have been shown to be useful in high-income countries, but that we don't have data to back up in our community. Thank you.
Okay. Quickly before Dr. Grandison, one last thing. What are you all looking for in the urine? That's an interesting one. And after Dr. Grandison, if you can come please to Dr. St. John, because he can speak to our local experience with colonoscopy. Because over the last year, he has done quite a number of them. So what are you looking for in the urine?
Great. We were looking for 3 metabolites. We've published the first paper on that. I can share it with your community through you so that you can see.
Yes.
One of the metabolites we are looking for is epuric and some glucose analytes that we found. I can't remember all of those 3 metabolites offhand.
No
but
problem.
there are 3 metabolites that we have shown that we found that were very useful.
Okay.
That some of those patients that have polyp and rectal cancer seem to excrete it in their urine.
Gotcha.
And those metabolites seem to be very unique with high sensitivity and specificity.
Okay.
We are hopeful that if we deploy that in South Africa and East Africa community and other African community, we want to work with Ghana, Tanzania, and South Africa.
And what is
if
the cost?
That also work very well. That may be something that we will be able to advise people from low middle income country to use, because we've been able to include this in a point of care device. Not something very small for now, but we hope we can reduce the size of the device in such a way that that device can be deployed in very rural environment to screen people in the community.
And what kind of price point? What kind of price point are you looking at?
But we are hopeful that in the next few years we'll be able to deploy.
Okay, how much for this kit? How much you hope is that this kit, or currently you're thinking this kit will cost? What kind of cost are we looking at?
Oh, currently we are looking at something like $5. Less than $5.
Less than $5 US. Wonderful.
Yes, $5 US.
Yeah, that is wonderful. So, all right, I'll go to Dr. Grandison in the room, and then we come to Dr. St. John.
Thanks, Dr. Griffith. Asking a question following on from Dr. Alatisha and also the point that was made by Dr. O'Shea. Certainly, screening in the general population, working as a general practitioner, has been a challenge because a lot of fear associated with persons going to get a colonoscopy. And then there are the complications that a person don't want to deal with their own fecal content. Do you think that there would be any consideration in the future, probably for something like breath methane testing and hydrogen ions in a breath state, because we know that that tends to be increased with persons who have more of the gut, given that they're eating more, for instance, the ultra-processed foods versus the foods that are high fiber, which is usually associated from a dietary standpoint with colon cancer outcomes.
Okay, well, I would say first off, that is a question that I think is best answered by Dr. Knapp and Prof. Alatisha, because I have very little knowledge of such a thing. What are your thoughts with regards to methane testing, breath methane testing, and hydrogen ions in the breath with regards to colon cancer detection or use as a screening tool? Greg, anything you know about this? Then Prof, anything you think you can add to that? And then we come to Dr. St. John.
Sincerely, I didn't hear the question very well, but Alex, can you hear the question?
Breath methane. So they're less, I don't know, it's coming from the room and we have a problem with the mic. So let me just see if I have it correctly. It is methane in the breath and hydrogen ions in the breath, and they use as a screening tool with regards to colonic cancer. And what are the thoughts on that? How close are we to something like that? What is the potential cost of something like that?
I can speak a bit to that.
Yeah, please do, please do.
So it's interesting that that was brought up because we just recently had a startup company in New Brunswick, which is the province adjacent Nova Scotia, who has specifically developed a prototype for breath metabolites, right? Or gases within the breast, and I'm not sure exactly because we're still going through the process of the non-disclosure agreements, et cetera, but they want to test as a breast cancer screening tool at our tertiary kind of women's institute. So there's definitely so a preliminary look, there are many startups exploring that space. It doesn't seem to be as far along as say as I think the other kind of hot topic, which is circulating tumor DNA. That seems a bit further along in terms of it's not ready for prime time, but I think we're quite close to seeing circulating tumor DNA both as a tool to help select who benefits from, say, chemotherapy, and so amongst people who already have colon cancer, but then also a bit further down the pipeline as a screening tool. That's about as much as I can answer in terms of that, but I know it's a space that's rapidly evolving, and I honestly do think, because someone mentioned, I think the intro speaker mentioned AI. I do think one of the positive outcomes of AI in the next 10 to 15 years is going to be the ability to analyze massive data sets like what would be generated by kind of chemical composition from exhaled air, or stool samples or blood samples to kind of tease out the signals that may be useful for screening and diagnosis. So I suspect we'll hear more.
Sloan Kettering, nothing that you shouldn't disclose, but in the context of, because I am curious, because realistically, when we're talking about resource poor settings, we're talking about cost. And then one of the first things I wanted to know with Prof. Letitia's test is how much it costs. And if you were saying that you got a test that is 5% with $5, with fairly high sensitivities and specificity, I think that's hard. It's hard to beat. It's hard to beat $5, man. And so at that point in time, I'm wondering, anything you hear coming down the pipelines before we get to Chabier? Alex, that
that was a question for me?
Yeah, it was a question.
Nothing that I am aware of. This is not me being secretive. There's nothing that I've heard about thus far coming down the pipeline in terms of the screening, from a screening standpoint.
Okay, well then over to Chabier with regards to local experience.
Right, so first things first, to answer Prof. Letitia's question about access to colonoscopy. As it stands, we have a unit with one suite, we have one processor, we have 2 adult colonoscopes, 1 pediatric colonoscope, and 2 gastroscopes. So one endoscopist can work at a time. We will probably get through like 10 procedures a day. We work 5 days a week. And so that puts us at 50 scopes a week. If we were to try to unroll that for the population over 45, which is 100,000 Barbadians, it would take us 40 years to get through all of those people. So obviously colonoscopy cannot be offered for everybody en masse. So one simple thing is to improve the infrastructure. So at least have a second or a third suite, duplicate the processors, and then have a cadre of scopes and improve the amount of nursing staff. Because in this room we have, myself, Dr. Griffith, Dr. Padmore, and maybe even Dr. Mon, who did some endoscopy training in the past, that could potentially scope simultaneously, such that we could ramp up those numbers. But that is where we are at this current point. When I returned to speak to the clinic that Dr. Alatishe has been running, which is the at-risk clinic or the symptomatic clinic, when I first returned, a patient with symptoms, let's say they went to Dr. Granderson's office, they had symptoms, they were referred to the hospital GI clinic, they were waiting a year to 2 years to be seen to then be given a date for colonoscopy. On my return, I had, through word of mouth and contacting the GPs and other specialists, patients could be referred to me directly and skip that queue, and within weeks to a month could get a colonoscopy. And so that's what we have been pushing. Dr. Maynard, who has returned from Catalonia in Spain, has also been pushing this direct to colonoscopy if you are symptomatic or if you have a positive FIT test. But that relies on nurse-led initiatives, such as what Esther does for the colon cancer initiative, which is to have a nurse practitioner liaison with the patient so that they can explain to them the bowel preparation, coming for the procedure, consent process, and throughput through the system. Even with that, we have been able to pick up quite a few patients who are symptomatic and intervene in a timely manner because we have this network, myself, Dr. Padmore, and Dr. Griffith. Generally, for example, if a patient comes to me with symptoms, I diagnose them, I will get them the staging investigations on the same day or within a week, and then I will try to have them on a surgery list within a month, which is much faster than what's happening before. So we have sort of started our ad hoc high-risk clinic or our symptomatic clinic, but with the current resources that we have, we are stretched to the breaking point. So if we were to unroll this national FIT test in the polyclinics en masse, we would probably have hundreds of positive FIT tests, within 3 to 6 months, and no way to really offer these people colonoscopies within the recommended guidelines of 1 to 2 months of a positive test. So I'm making a plug for resources. We need more infrastructure. We need more equipment. Because at this point, if one of these 2 colonoscopes breaks down, we are really in dire straits. So that's where we're at this point. I do agree with Dr. Knapp about getting data on what our positive rates have yielded. I have seen patients with hemorrhoids that have flagged positive tests and older patients with diverticulosis that have flagged positive tests. But I think it's a bit early for us to say that the qualitative FIT cannot work in Barbados. It is a bit cheaper than the quantitative FIT. And in the absence of any better tests at this point, I think we have to go with what we have, because we cannot offer colonoscopy to everybody over the age of 45 or over the age of 50. They just will be waiting.
Okay, so as with any discussion, it's nice to bring people from in the room. And there was a discussion earlier with regards to genetics. Prof. Alatishe raised the fact that he was seeing high MSI, but left-sided disease, which to anybody but surgeons makes no difference at all. But high MSI is a particular situation where those particular genetics create polyps more so on the right side of the colon, and they increase incidence there. So I was interested in having a discussion with Dr. Reed from pathology. Okay, from Dr. Reed from pathology, if you can just intervene, and then we can go, up to the bar. So at that point, why I wanted to bring in Dr. Reed is what are your thoughts with this MSI and left side? What are we seeing in our environment with regard to sidedness of colonic tumor? And what do we know so far with regards to the genetics of colon cancer in our environment?
So as mentioned by Prof, the frequency of MSI colon cancers in Nigeria is higher than what is recorded for the rest of the population, the Western population. It's expected that 15% of colon cancers should be what we call MSI, which stands for microstatic instability. It's just a genetic subtype of colon cancer. And I think what is important for the public to know is that MSA has two groups. You have the type that's related to what we call a hereditary risk. So it's something that runs in the family, and that's called Lynch syndrome. And according to the international data, about 3% of colon cancers that fall into that MSA category will be people with Lynch syndrome, meaning it's something that runs in the family. And then the rest, you just get it sporadically. What's important about MSA is that even though the percentage of people with Lynch syndrome is small, if we identify one person with Lynch syndrome in the population, we not only change the course for them with respect to follow-up for colon cancer, but we change the course for their relatives, their first-degree relatives. And it's not just for colon cancer, it's for all the other cancers now that those persons that are at risk of. So the ability to detect MSA in colon cancer.
So if you can please, if you can outline those cancers there, because there's some people on
there.
there.
Include endometrial cancer in women, gastric cancer, right? A whole variety, pancreatic to some extent, a whole variety of cancers that can be now more closely surveilled in those patients because we detected MSA in the colon cancer, right? So the implications of this testing will be far-reaching. With respect to the location, most of these tend to be right-sided, but it must be noted that there is sporadic MSA, and a lot of the sporadic cases, yes, are right-sided. Lynch is a slightly different beast in that with Lynch syndrome, the precursor lesions in Lynch are not the same as for sporadic colon cancer, right? I'm not sure exactly why Nigeria is seeing more left-sided MSA colon cancers, whereas the rest of the world is seeing more right-sided. Right now, the only data that we have on MSA in Barbados is retrospective, and it was a very small number of patients. We didn't really find that pattern. Actually, all the cases that showed MSA in our setting, the small number of cases, all of those were right-sided, right? So there's a difference there. Not sure why that difference
But
is.
what sidedness are you seeing most in our environment here in Barbados? Are you
Our
also
environment, well, it varies. For people under 50, left-sided tends to predominate, definitely for people under 50. And that is in keeping with what we see in other populations of African descent. But for the general population, somebody else have to speak to the data for the general population. But,
Just to educate the non-pathologists here, how are we going about getting the MSI testing on our specimens?
okay. Right. For currently, MSA testing is all externally sourced. There are two ways you can do it here. So there's a test called immunohistochemistry. Basically, that's just a test that looks at the expression of certain proteins by the tumor. And we find that tumors that have this property, the proteins are not expressed. And that's how we're able to tell that those tumors are MSA. The other way that you can do it is that you can actually look at the gene expression in the tumor. You can look at the genes in the tumor and you actually look for microsatellite instability using a test called PCR. So there are two ways. You can use PCR or the bottom line is that right now, it creates an issue with respect to cost, right? Because these tests are expensive. So what ideally we would like to be able to offer one of these or both of these in the local setting to patients. Yeah.
the indulgence, yes? So, Dr. Goddard, I know you came here as a guest, but I'm going to have you say a word if you don't mind. And sorry, Dr. Eastman, just give me a minute because as the moderator, it's my job to chain this discussion, and this is a very interesting juncture. Please forgive me. So at this point, why is this interesting is that I know the possibility exists for us to do PCR. And I'm wondering, as a geneticist, so Dr. Goddard is a geneticist, and realistically, we are very lucky to have her here. She was last in Paris, and on her stop from Paris, we were able to get her in this environment. So I am gonna ask, what are your thoughts with regards to PCR? Do you think that can bring our cost in down? And roughly where you think that price point could be if we do PCR in our environment?
I couldn't price it without doing more investigation. I think having PCR and having genetic testing would definitely be something, and having it locally would really be something that is powerful. And you can always look at local sourcing, closer resources in terms of bringing the pricing down and just trying to have it here. There are two advantages. One, you can offer the test at a lower rate depending on what it costs in overhead. And two, that also gives you research power. So you can do more investigations, learn more about the genetics in the population, and get a better idea of how you can use genetic screening and to let patients know what the risk could potentially be, to know what kind of diagnosis they're looking at. I actually have my hand up because I wanted to make an additional comment. We talked about diet, we talked about genetics, and people will always ask about diet because that's something you can control, that's something that you have some power over. And we always want to talk about genetics because that's the inherent risk factor. That's a way of calculating how you might develop the disease or someone in your family might be affected. But there's actually an intersection of the two of those that I kind of wanted to toss out there. It's something called the gut microbiota, because what you eat affects the internal environment of your stomach and then of your digestive canal, the colon, of everything else. And then the interesting thing about that is that the genetics of the person will also shape what the impact is of what you eat. So we're seeing these differences between the Nigerian diet and what we might describe as the classical Western diet. And then we're seeing these differences in incidence rates in Barbados. And there's always the possibility that what we might call the classic Barbadian diet has its own impact. And that's something that we can also potentially study here, because it's something that when you look at it from above, you're like, we don't have the resources to do that, but it's something that you could potentially partner with other people to do, that you can, and it gives you an additional power to tell your patients and tell people who are like, look, I've had somebody in my family who has had this disease. What can I eat to keep my risk down? What can I look at to do that? And it's a way of really quantifying that and paring down, and it's a very valuable data set that the research community as a whole has really started talking about very actively.
It's true.
So I actually wanted to ask a bit more about introduce the microbiome before she had spoken about it, because I came across studies that talked about the role of E. coli, particularly in colon cancer, developing in younger patients. So my question was really about, given the worldwide trend of an increased incidence in younger persons, are we seeing a similar trend in our population? And have we considered the role of the microbiome and the actual early exposure to certain E. coli strands in causing our population to develop colon cancer?
Are between 39 and 45, I believe. So we definitely have an increase, and there is a projection to mirror worldwide data that is going to trend up as well. And that is why 45 is a new 50 in terms of the cutoff. And certainly I start to talk to patients, about 40 being a new 45 all from now, because there is data that shows that in the Afro-Caribbean, African-American population, there is that increased incidence at a younger age, and the disease is much more aggressive. So you're finding them at a higher stage. So just, for me, anecdotally at this point, because we don't have the data, but I had a 47-year-old gentleman present with a neuroobstructing lesion just last week. And he came with symptoms, right? So definitely, it is a trend.
Okay, so as regards to the microbiome, let's see, Dr. Doyle, I just see you. I don't know if you were wanting to say something. So if you want to address the microbiome, or if you want to say something fresh, or do both, it would be better. You're mute, Alex. At least I hope is you.
You can hear me?
Yeah, you can hear you now, yes.
Okay. My comment was more about a holistic view of how we look at colon cancer, specifically in cancer in general on the island. From the discussions that you guys are having, I think we may tend to, and I know because I've been in the environment, operate in silos where there is a surgical aspect of the treatment of colon cancer, and there's a research aspect of colon cancer. And I don't think that we marry the two of them well. And I think that's something that we need to start to look at in terms of our approach to trying to tackle the problem, where we need to see research in the area as influencing the management from a primary, secondary, and tertiary care standpoint. So that was the point that I wanted to make. Aline is talking about doing MSI testing for colorectal cancer specimens. Is universally accepted that all of the specimens that we do and send off to pathology and surgery should be tested for MSI because it has implications for patients in terms of treatment as well, whether they may be candidates for immunotherapy, for example, or whether they may respond to certain chemotherapy agents depending on the stage of their disease. So the research aspect informs what we do from a clinical standpoint. And I think if there is one thing that I would want the powers that be to take from a meeting like this is that maybe we need to start coalescing each of these different arms under one body, where the research arm and the clinical arm are both, for want of a better term, working hand in hand to try to influence the outcomes that we have for colorectal cancer. I know we are trying it in the Caribbean Colon Cancer Initiative, but that is one group that is doing it. I think we need a island-wide and even a region-wide approach to approaching these issues. And that was my take on it.
Or three of our research collaborators that may be on the live stream at the moment. I want to, unfortunately, I'm going to do this how we can do this. So I want to big up our large of Dr. Wesley Francis from Bahamas, and Professor Shamir Kowich from Trinidad, and Professor Shanetta Johnson from, she previously or more host soon, or if not already, at Meharry. Realistically, those were the original research collaborators we were having. And now that we're moving over into wider collaborations, I think it is necessary that we do or get more people involved with regards to what Alex is saying. Dr. Knapp, anything you want to speak to about the microbiome? And then Prof. Alatisha, if you could please speak to what the dietary situation with regards to Nigerian colon cancer was looking like. Because when I hear about this, I'm very interested in hearing what is that, because realistically, my basic genetics comes from a saying from sixth form, I think, biology. It says the phenotype is influenced by the genotype and the environment. And that is exactly the argument with regards to the microbiome and the genes. So I think what that means to, non-people doing biology in sixth form, that means that what you see of a thing is the result of the genes that thing has and the environment in which that thing was raised or exposed. So I'm really curious about what is going on with the diet in Nigeria, given that I am assuming that if 60% of your initial population came from Nigeria, predominantly Igbo populations, then I would be interested in what those genetics are looking like. What are we having these differences now versus then? So Dr. Knapp, please, if anything about the microbiome. Prof. Aletiche, please, if anything about the Nigerian diet specifically.
The one tangible thing about the microbiome that's I think I'm glad it came up. It's another area of almost explosive research, no pun intended. But what's really interesting in the link to what we just talked about is that if you have a certain type of colon cancer, we've been talking about this MSI or this type of colon cancer that has this unique molecular profile, which means that the immune system, with the right drug, can identify and destroy that colon cancer. And it seems to be more common in Nigeria, maybe also in Barbados. What's interesting is we know that there is a certain microbiome that makes those treatments much more efficacious. And that's a huge area of research. There are certain bacteria that you can modify and modulate to improve the treatment effect for these types of colon cancer. So that's on the treatment side, but that's something that's very tangible and is really, it's really exciting. And I think it speaks to just how little we understand the interaction between our immune system, how the immune system is trained probably in large part by the gut, in the colon specifically, and how that may A, set us up for cancer, but B, how it may help us fight cancer once it arises. So it's a super interesting area of research. And the one thing that does seem to be a very low-hanging fruit in that space is, in fact, high fiber, very high fiber, like aiming for 20 grams a day. You're giving the substrate needed, you're feeding the type of bacteria that you want to grow. So it's like you're preferentially watering the good bacteria, if you will, the good plants in the colon. And increasing fiber doesn't cost anything, right? It's a diet modification. So I'm glad you brought it up. It's an area I'm really interested in, both personally and from a research point of view.
Just me as to when I heard about this dietary thing with Nigeria, because there's a lot of yam eaten, and yam is a high fiber food. So by right, I'm curious as to what was it about the Nigerian diet that was problematic. So, Prof, if you can speak to this a little bit. What was the research showing with regards to diet and colon cancer in Nigeria?
Yeah, can you hear me, please?
Yeah, I'm hearing you, Prof.
Yeah, we just concluded a study looking at 1,200 control. Eventually, we had to get to 1,500 control and 750 cases. And we had an initial analysis looking at the diet and the role of exercise in the occurrence of colorectal cancer. What is actually wrong in our community? Why are they developing colorectal cancer? Just like you said, Prof, you know that most of our diet are high fiber. Interestingly, we all know that doing food or supplement study is very challenging because there are a lot of confounding factors. But despite that, we try our best to control as much as we can. And what we found is that the meat eaters are actually more exposed to developing colorectal cancer compared to the fiber eaters, which is an interesting finding in our study. Of course, we also found that obesity also play a very strong role in the occurrence of colorectal cancer. But the most important part of the obesity, because we did try to measure, do a bioimpedance test to assess different types of obesity that a patient has, truncal obesity and the like. We found that those that have truncal obesity tend to be more prone to develop colorectal cancer compared to others. So those are interesting things. The data is still being analyzed. It seems as if some of the things that is in the literature as regard diet still hold true in our community, and that is challenging. Meaning that means that our diet is changing, though we felt that it is not changing. We know that most Africans are now beginning to eat a lot of fast food, and that seems to be playing a role in increasing the incidence and the propensity to develop colorectal cancer in our environment. Talking a little about the microbiome as, and the role of microbiome in the occurrence of colorectal cancer. Sincerely, that's an interesting study with a very little data. In our series, which we presented that in ASCO GI meeting last year, our preliminary data shows that there's some anaerobe that are quite unique in those patients that have colorectal cancer that are not found in those that does not have in our controls. And those anaerobes has actually been implicated in the occurrence of colorectal cancer in some other environment and some other diseases. So what we are hoping is that we are trying to do larger studies to be able to substantiate that initial findings to see if we can eradicate some of these anaerobe at a later in another studies to see if that can help us to reduce the occurrence of colorectal cancer in our environment. Believe you me, is a very fertile area of study, which I won't be surprised if the microbiome in Barbados and the Caribbean countries is definitely different from what is found in our environment. The more we look, the more we'll be able to find, and the more we'll be able to help our community.
Thank you very much, Prof. I want to do a couple of things because I see time is getting low. We really started at around, unfortunately, 1:45. And so I would like to keep to the 2 hours thing. So we're looking at about 20 minutes. So realistically, I want to do a couple of things, please, if I may. Any of the non-medical persons in the environment, would they want to ask a question? No. I say that this panel is a panel that has been together and the persons in the room pretty competent. I can be honest with you. I am the least amongst the apostles. So if anybody wants to ask a question, please feel free to do so. If not, I can take a little creative license and I'm going to ask something. So I'm going to let them prepare from now. It is not often that you have a panel convened like this with expertise in a particular area. And I noticed there are currently 1, 2, 3 surgical trainees in the room. And at that point, each of you should pose a question, or I will ask that you pose a question to this particular panel. Because in reality, if I'm going to put it to you like this, the questions that I was asking was because I wanted to know. I really was curious about this in amongst these persons. These people were teaching me. So at this point, I think it is necessary that you take the opportunity to have them discuss anything you want them to discuss. This colorectal group at the moment should be on the top of things, if I would say it like that. So at this point, any of the non-medical persons, would you like to ask a question? Oh, and the online live stream people, I don't know how you do it. I don't know if you put a comment in the YouTube. If you want to, please feel free to ask a question. Dr. Thompson will read them. All right, so let's begin. Lady in the orange, thank you very much.
Just a very quick question. Dr. Padmore did a trial.
Mm-hmm.
And I don't know if he wants to say something about it because I want to know about the efficacy of that.
Oh,
See,
dear.
It's being questioned.
Yeah.
I just want to know if you found it in the genes, what does that mean? Thank you.
Yeah, that's a good question. It's a trial, so we did at the Barbados Cancer Society comparison with we call it liquid biopsy, which is called, the actual brand was Colotest, and we compared it to FitTest. We had about, in terms of, for the data collection period, just over 600 participants, and these are asymptomatic patients. We are about to publish the data. So again, this is early data. It had highlighted a higher sensitivity, which is the ability to pick up patients with colon cancer or genetic predisposition to. So from my memory, we had about just over 10 to 12 persons with positive tests. So the tests were broken down into your risk of having a problem. So it's like low, intermediate, and high risk. So patients that were high and intermediate risk were about 10 to 14 persons from my memory. And out of those persons, we then followed up with colonoscopy, and we did detect, I think it's about 2 persons with colon cancer. But again, these are early data. We're still analyzing the data, and this is in comparison to the FIT pickup rate. So what you would notice is that we're doing several different modalities aiming towards the same answer, trying to figure out which test is most efficacious for Barbados. That test was sponsored though by Yale University. So that genetic blood or saliva test was sponsored because that had some cost attached. I think it's about $500 US per test, which was free to us, but for that study. So again, cost also has to come into play. But good question that you asked.
Okay, may I speak?
Yeah.
So let's put a couple of things out there. So at the moment, I think it's necessary, especially I don't know how many people online that we're having a discussion so we understand what the issue is. Fundamentally, we need a screening tool that's working in our environment. The issue that we look at in all resource poor settings relates to cost and because the ultimate test is known to be expensive. So the colonoscopy is expensive by its very nature. And given that it's expensive by its nature, you'd want to select down people to get this actual definitive test in as cheap a way as possible, if I can say it like that. It is why that is very interesting that if you can come up with a test that costs $10, a urine-based test, that would be very interesting, $10 Barbados dollars. It's very interesting in our environment because the FIT costs about $50, yes? And then if this Cologuard thing costs Colo test, costs $1,000, then ultimately you're going up because the colonoscopy cost is still fixed. So it's how can we screen a large amount of asymptomatic people in as cost-effective a way as possible, because screening is always on asymptomatic individuals. Any discussions from the panels with regards to what was said? Thank you for Dr. Padmore. I am very keen to hear those results, though, to be honest with you, because I am interested very much in what is our genetics in our environment, and I think if we find a genetics-based test, I don't know. I try to link these things together, man. Yeah? That's how it is. So, anybody else in the public?
Hi, good afternoon, everyone. Good afternoon, panel. Thank you very much for this discussion. I had a question, again, for the public specifically. I'd like to hear what their fears are about colonoscopy, because I do think that's a major limiting factor to some of our general public going for their screening tests, or even warranted tests for colonoscopy. So I'd like to hear from members of the public by chat or here in the audience what their fears are and see if we can address it to them.
Anybody in the audience wants to volunteer that? If not, I can speak to
what you have noticed.
So,
the last one, the liquid that you take the negative for was horrible. And thinking about doing that, I have a family history, so I do mine every 5 years. I had a heart. And thinking about the last mixture that I was awful compared to the previous 2. Was it changed?
Did you have it from the hospital here?
Repeat it so people online can hear.
So the challenge she had was with the bowel preparation. Did you have the bowel preparation from the hospital here? It was a big bottle with crystals in the bottom? Right. So that is the cheapest, in terms of cost, a way to be bowel prepped. But it is the most difficult to tolerate. So there are alternatives where you take a lot less of the actual prep, but then you have to drink a lot more clear liquids around it. So, but yeah, so if we brought down, the public's fears about colonoscopy, the one that I tell them is that the hardest to tolerate is the bowel prep. And Barbadians like to eat food, and the fact that you're starving them, quote unquote, for a day or two, depending on their bowel transit, people have to go on a clear liquid diet at least a day to 2 days before, and then the bowel preparation, that's the hardest part for them. But whatever test you do, if you do a fit test and it's positive, you still will, end up having to go for a colonoscopy. So I always tell them, that's something that you will have to live with. The second thing is the risk of having sedation or full anesthesia, because depending on who's doing the test, you might either have it under conscious sedation, which I know in Canada still there's a large percentage of patients getting conscious sedation. And then in America, and then in some of the centers here, we do full or deeper sedation, general anesthesia, the risk of going under, quote unquote, for the procedure. And generally, that's something that we prepare the patients for. We have a pre-anesthesia evaluation or pre-anesthesia clinic to mitigate that risk. And then there's the risk associated with the procedure itself. And what we like to say is that you're more likely to get bitten by a shark going swimming in Carlisle Bay than to have a perforation from a colonoscopy. It is less than 1 in 1,000, and generally there are patients who we know are higher risk, are smaller, petite old ladies who've had pelvic radiation or who've had hysterectomy, so there's more scar tissue. And what I have found, I reassure patients by telling them, if I have any challenges or any of the endoscopists have any challenges, we tend to abort early and then send them for the virtual colonoscopy, which is the CT colonography, which can look at the colon to see if there's anything large and obvious. So I try to mitigate them by saying them the risk is very low in our experience and in the literature. And then if there are any perceived challenges, rather than try to push through and cause a problem, we abandon early and send you for the virtual colonoscopy to look at the rest of the colon that we may not have seen if we only were able to get a quarter of the way through, right? But generally, we have a conversation with the patients to allay their fears. But the most important thing is that whatever test you have done, you have to be prepared to deal with the consequences. So if it is that we found a cancer or a polyp or something, you would have to be prepared to have that treated, whether it be by surgery or advanced endoscopy. And if you didn't want to have that done, then maybe you shouldn't be having the test in the first place.
All right, thank you very much, Dr. St. John. So, Prof. Letitia, I remember while we were in Nigeria there, you were talking to me about prep, the bowel prep that you use, because you have people coming from pretty far, and there's, I guess, some issues with prep, as they have issues with prep here. Now, I noticed that Dr. St. John says he gives them a fast, or I am assuming you allow clear fluids?
Clear fluids.
Yeah, he allows clear fluids for pretty much a day, he said sometimes 2, while doing the prep. I'm wondering, what are your thoughts about this? What prep do you use? Because I noticed you were not restricting diet in any way at all, and the preps were pretty good, I can be honest with you. So tell me about the prep you use and a little bit about what you think, because maybe if you're not restricting diet, more persons in the public might be interested in having this done. Talk to me.
Yeah, can you hear me, please?
Yes, I'm hearing you, sir.
Yeah, I agree with everything that has been said, but bowel preparation is one of the major problems with colonoscopy, as well as the sedation, but which we know how to manage. The complication from colonoscopy is very, very low, and it's something that in an experience, and you can go to sleep and release yourself to your endoscopist. Now, in the bit of improving, reducing the burden from bowel prep, we'll be moving from one agent to the other to see which one works very well for our patients. Currently, what we use is trisulfate. This is magnesium. There are triple sulfates that are within the agent, and it comes in 2 liters. And what we do, we ask the patient to take a liter in the evening. Just take liquid diet. They can take any liquid diet they like a day before the procedure, and they take a liter in the evening of the procedure, and the second liter in the morning, and then we do the colonoscopy that same day. That seems to be better tolerated than the polyethylene glycol that you have to take a lot of fluid. And so currently what we use is a trisulfate. The brand that we have is what we call what's the name again? I'm trying to remember the exact name.
No,
If I remember, I'll text. Hello?
Picolax or Picoprep?
No, it's not Picolax. Picolax is Coloprep is what is the name
Coloprep,
of what
okay.
we use. We use Coloprep. It's a trisulfate. Picolax is a phosphate group and phosphate agent, and we know phosphate has some problem, especially for patients that have renal issues. So we don't use Picolax. We use Coloprep, which is a trisulfate.
So,
and it seems to work very well for our environment.
So you use liquid diet as well? Liquid diet,
yes,
no fast. Liquid diet?
Liquid diet just a day before.
No, just a day
not
before.
Clear
So
diet.
you stop solids as well. Clear. Okay, but not clear, just any liquids they want.
Any liquid they want, including fruits. We also encourage them to take some fruits. And that seems to help them to tolerate the bowel prep better.
So fruits as well. You let them liquid diet and fruits.
Yes.
Okay. Yeah, that's much better. Much better. And you found that you have no issues with your prep. No residual, no increased amounts of pooling, stool pooling, nothing.
Yeah, we still did. Dr. Knapp was with us a few weeks ago, and we did for our colonoscopy training. The bowel prep is excellent.
Yeah.
In almost all of them.
And that,
occasionally we may add Ducolas to it, especially if the patient have constipation in the past, a history of constipation.
Understood.
But aside from that, they tolerate the Coloprep very well.
Very well. Okay. And Greg, what you're using in Canada, you're associated, you're using the fast?
I can vouch that. Like, I've never.
Hello? Yeah, I was saying, we're breaking up, it seems. Let me repeat myself, just to be sure. I was asking, what do you use in Canada? And are you using, how much dietary cessation are you using?
Yeah. Just to corroborate what Prof just said, we did 30 colonoscopies in 3 days, and we didn't have a single bad prep. Yeah. And this is with the longest colons maybe in the world. And that's remarkable, because if we do 30 preps here in Halifax, you'll get a poor prep probably 10% of the time. And I know my colleague, Dr. Spence, has tried to bring back the colo prep for Halifax. Like, that was one of the take-home messages from our last year's course in Nigeria, which was, we need to step up our game. Our preps are not as good. We're using the Pico Salax, and it's not, we're also quite liberal. Like, they're really just, clear diet, like the 2 sachets, and it's kind of it's a clear diet for 12 hours before, but that's not good enough. We have quite a number of patients that are getting repeat scopes because of inadequate prep, and that's not good we're also tight on resources, and we can't afford to have a 10% poor prep rate.
Yeah.
Just one question for you, Dr. Knapp. With these so-called colons that were longest in the world, were you doing anything different with your technique? What do you do, like a lot of water-based technique now, or just from my education?
Well, I think Prof has a great story. When I was when I came to Nigeria for my 6 months, and we did this fit validation. So we had generated quite a number of scopes. My cecal intubation rate coming out of training in Canada, practice for a year, was over the kind of benchmark threshold, 90 plus. And in my first 10 scopes in Nigeria, I was batting like 50%. And I had to be mentored by Prof. Alatishe in the way of the Nigerian colonoscopy. And really what it was is, which was amazing. It was an amazing learning experience. Surgeons are always eating humble pie. And I continue, but it was a lot more positioning, like much earlier, from left lateral onto back over to right side sometimes. Right. Much earlier positioning to get and to prevent the loops at both the splenic and then the fairly unique transverse loop, which I had never really experienced in Halifax. I think we've got foreshortened mini colons in Nova Scotia compared to the Nigerian colon. So it wasn't that much more water. We were using a lot of water before, but it was really the early frequent positioning changes that I was not doing.
Yeah, definitely. I've heard.
We would do all our scopes in left lateral.
Right. You get through as much as you can, and then you kind of grudgingly change your position.
Exactly. Whereas Prof was like early position, a little bit of focal, pressure here and there, but it was almost like the anticipatory position change, which was novel for me.
Right. I had heard that in Toronto from a GI, advanced GI, but we tend to just, we're lazy. We kind of just, get as far as we can go. And then, when we struggle after about 5 attempts, then we will change position. Thanks a lot.
Yeah. So I'll tell you though, I would like Dr. Panmure, having spent a month with Prof. Alatishe and doing endoscopies over there, both general endoscopy, colonoscopies, and ERCP. So to be honest with you, Paddy was getting it in. How do you feel about, let's say, the colons here versus there? Because that was contrasting Canada versus Nigeria. What are your thoughts on Barbados versus Nigeria as a person that's close in both environments?
No, I agree with Dr. Knapp about the colons in Nigeria. Definitely longer and more tortuous to navigate. So like similarly to Dr. Knapp, I thought I felt comfortable doing scopes until I tried there. I had to kind of back out early as well too. Because you don't want to cause any damage, especially when you're visiting. You're visiting a different area. Because again, persons are watching, so you don't want to really want that come and cause a big issue. So, but yeah, it's important to have these experiences because then you know how to tailor and learn from. The thing is with surgery and any specialty in medicine, there's always a learning curve and learning experience. You always think you know, but is always be key about being willing to learn from others who also keep doing more than you, right? But yeah, thanks again, Prof, for the experience.
Yeah. So what time we down to? So any other questions? Anything from the panel? If not, over to the 3 surgical residents. I'm gonna go from junior to senior in that case. Sorry, not to put you all on the spot, but boy, this is live. Ask a question. It's not hard. Anything from the panel? Okay, so first, Dr. Bentham, over to you. What is your question to the group of the day?
So my question is...
Mike, so the guys can hear it live.
Okay, so my question is, given that we're trying to find a screening modality to help us detect the colon cancer at an earlier stage, if we're using FIT testing, as a stool test comparative to the other ones. So looking at the MP2K or the Cologuard test, I'm not sure how much in terms of expense what each individual test costs, but if the UniFit test in Nigeria was found to be not as effective, meaning there was a high positive rate, why use that one as opposed to the other options for us?
Okay, so let me break that down into 2 questions. based on all discussed today and the differences in cost with respect to fit testing, quantitative versus qualitative versus but color test is not quite in the market yet, is it? No, but Cologuard, which would be one, the genetics-based test. What would your thoughts be with which one should we begin with in our environment as a primary screening tool? And what would be the M2PK? What would be your thoughts as M2PK as a screening modality in colon cancer? So let's begin. Let's get 3 responses from that from the external panel. Alex, any thoughts? Greg Knapp, any thoughts? Prof, any thoughts?
You were breaking up. I didn't hear the question fully.
Oh, it was breaking up. Sorry, let me do it again. There are 2 questions here. With regards to the M2PK, what are your thoughts about that as a screening modality? Second question, with regards to the primary screening tool for colon cancer in our environment, given all that is known, which of the 3 do you think would work? The quantitative fit, qualitative fit, Cologuard tool, genetics testing in terms of colon cancer screening. Which of these 3 you think would be best in our environment?
If you can hear me, because I'm almost getting to a place where the network is bad. What I tell people is that what works is what people are able to do and do on a routine basis and be able to comply with it, and which the system can also afford to deploy. I got the statistics of the colonoscopy volume and the capacity in Barbados. Definitely, you cannot deploy that kind of a thing in that setting. So what is useful should be what the system can deploy and the patient will be able to afford and abide with it. If we are talking of fit every 2 years or every year, if it's something that in that environment you are sure that the individual will be able to do and they will be able to comply with, and if they have a positive result, they will be able to go for colonoscopy and the system will be able to provide that colonoscopy, so be it. So the screening tool that should be deployed in an environment should be the one that is the patient can abide, can follow through, and the system can also accommodate. That would be my quick way of answering what is the best screening tools in an environment. Thank you.
So for the local setting, it would be the qualitative fit, because it will be free in the polyclinics very soon. I figure in the next few months. And the M2PK costs, I think, between $150 to $200. And I think the Cologuard is not available in Barbados, but I would imagine it would be more expensive if you were to try to bring it in or do it.
What do you think about M2PK as a screening modality for colon cancer, though?
I'm really not. I don't think it's a good screening tool for colon cancer, if I'm being honest. It is not anywhere near sensitive and specific enough. It has not been validated in randomized controlled trials. But for those who are touting it and encouraging patients to do it, they tend to do it, from my experience in the private sector, they tend to do it in conjunction with the FIT test. And so, if it's bringing the conversation up about screening and it's getting the patients to us to get colonoscopy, I'm not completely against it, but it would not be my favorite.
So, Shabir, let me ask a question, because this is a common one, and maybe I should ask this to the group, given that it came up. So there are patients, as Shabir said, is combined with FIT test. So their FIT test is negative, but the M2PK is positive, and then they're referred. Those are always a little bit of a challenge. What would be your thoughts? Does the panel have any thoughts with regards to the management of such patients?
Well, for me, my hands are tied to offer the patient a colonoscopy, unfortunately. It's the same as the patient who... So what has been happening with this pilot study in the polyclinics is that patients, so the doctors who are administering, or the nurses who are administering the test, are not even following their exclusion or inclusion criteria. So we're getting patients who say, I have hemorrhoids, I'm having PR bleeding, and they're doing the FIT test and it's positive. So then once the test is positive, you have to do the colonoscopy, right? And then there are patients over 75. So I've had patients 78, 85, that they've been giving them the fit test, and then it's positive, we have to do something. And then you have to then have a conversation with them saying, well, you're fit enough for the colonoscopy. If we were to find something, let's say you needed a colectomy, I believe that from your performance status, you're fit enough, but would you be willing to undergo, go on this journey? So for example, I had a patient who came and she lives alone. She couldn't even, explain to me her drug history. She had a stroke sometime in the past. So her taxi dropped her. She had no family that, you could even explain bowel prep, a surgery, but she had a fit test and it was positive. What do you do with that patient? So I think we have to look at all of these things.
Okay, any thoughts on the panel? Yes, Alex.
Jeremy, okay. Yeah, so looking at just the numbers, the sensitivity for colorectal cancer for the M2PK stool test is about 80%. While for advanced adenomas is about 40 to 50%, which is a coin toss. It has specificity about 80 to 95%, which is way below the numbers that you're having for the FIT testing, which is approaching 80% in terms of sensitivity. So I think for us, from a public standpoint, for national screening, FIT is going to be the way that we'll have to go to then figure out those patients then who may then go on to need a colonoscopy. As was said before, there obviously is going to be an increase in endoscopic demand, and we're going to have to find ways to mitigate that. But based on what we have currently in terms of what will be most cost effective, I think FIT testing is going to be, for us, the way to go. We then may need to do some type of research and prospectively look at the testing that we're doing to then try to figure out if, for our local setting, we should continue with that. But to start out, I think.
Okay, you dropped there, Doyle, but in the interest of time, we got 2 more questions to go. So let me just say, so on the panel right now are 1, 2, 3, 4 surgical oncologists. Basically, 2 of those are HPB surgeons as well. You have a colorectal surgeon. Dr. Makeda M. Kelly, this can have anything to do with colorectal cancer, right? I want to know, do you have a question? Bring your question to the table. There's a lot of weight on this panel. So ask them whatever you would like. This could be highly technical. Excuse us for a minute. This might get a little surgical. Yeah?
Anything that's in your mind. It could be a simple question. It could be,
You knew it was coming.
Good afternoon, everyone.
Yeah.
So I think it was a very extensive discussion, and I honestly believe that majority of my questions were answered just with the discussion. My question was more so, I guess, for the confident audience, so more so maybe the pathologist, if he could help, but it relates to the circulating tumor DNA, and how it will benefit us. So we know that we're moving more towards the liquid biopsies that we would consider less invasive. So as it relates to the circulating DNA, we use blood, but we know it's not very specific. So then how do we take that, a very expensive test that we might not particularly have readily available to us, and then say, okay, we want this. And then when you do get that test done, then how do you determine whether or not you're going to get a targeted assay versus the next generation sequencing that we're moving towards to pick up multiple different mutations?
Yeah, Alain touch. You don't want to let Alain touch that. As a pathologist.
Before Alain touches on that, or while he's touching on it, I want Dr. Knapp to tell us his experience with the circulated tumor DNA in Canada, because I know when I was there, it was something that wasn't available, widely in the public system in terms of in Ontario where I was training. And because of how expensive it was and the implications of a positive or negative test, we were having headaches with patients who had it done, and what we were to do with them and those kinds of things. So I'll let our resident pathologist speak first, but then I wanted to ask Dr. Knapp's experience.
Okay. Ali?
Well, my knowledge on the circulating tumor DNA so far,
You might take the mic if you may.
so far I think it has been most useful in risk stratifying persons, especially persons with stage 2 or 3 colon cancer, to determine, which group would be high risk and probably would require additional therapy, like chemotherapy. I think with respect to screening, based on my limited knowledge, I don't think it's quite ready for prime time in regards to screening. And then the other challenge with a lot of these tests circulating through the DNA is the analytical aspect, like being able to, verify the data, validate the data. A lot of these tests have to be validated in randomized controlled trials. A lot of them are not necessarily validated as yet. So I think it's promising, but it still has a very long way to go. And so I think the main thing that I see it being pushed for is risk stratification. That's a big problem. What do we do with persons who have stage 2 colon cancer to determine if they need additional therapies?
Correct.
Or if they can be treated by resection. Yeah. So I would like to not speak to the experience in Canada regarding circulating tumor DNA and other liquid biopsy tests.
Dr. Knapp.
So full disclosure, we are also not but we do have it looking at tailoring adjuvant chemotherapy based off of a particular proprietary circulating tumor DNA platform. And so, yeah, it's definitely, I totally agree with you. It's not prime time. It's not, we're on the surgical or the medical oncology side who are using it yet to dictate decisions. I think when the use a bunch of private, just like Oncotype and simultaneously validating different workflows, and that that's going to be a challenge until either one emerges as the dominant. Like it's definitely, we're not using it. It's not part of our day-to-day clinical experience of colon cancer care.
Okay.
Okay. Thank you very much, Dr. Knapp. So Dr. Phillips, the most senior of the group. Yeah? Yeah, man. Give him a question then.
Good afternoon, good afternoon to everyone. With the advancement of genetics and genomics and molecular subclassifications, especially in cancers such as breast and gastric, my question is in regards to the fact that we acknowledge that our population, as well as in Nigeria, presenting more advanced stage colon cancer. The question is whether or not they were able to molecularly subclassify what kind of cancers, in a particular molecular subtype, and if there is any trend towards trying to molecularly subclassify these all over the world to see if there can be any linkages towards geographical, genetic, or ethnic and cultural traits that may reflect why these particular molecular subtypes in the present where they are.
Excellent question. Emil, Prof. Letitia, did you hear that one?
No, I didn't hear it.
Here you go, really come again, Emil. That is quick. Yeah, man, drop that, Emil.
So I was saying that the advancement of genetics and genomics and molecular.
Can you hear Prof. Letitia? This is a very important question, and you alone can answer this one. Please. Are you hearing us?
I can hear you, but the question was very far. Alex, can you?
Yeah,
it sounded far away from me as well.
Alex, can you answer it?
Oh. No, we can't hear it very well.
Oh, you're dropping out. Yeah, it's his mic. Okay, please use my
Hello?
mic. Somebody carry my mic. I think it's just the connection, man. Yeah, man, come down to the front, man. Yeah, what you talking about? Emily has a proper question, man.
Hello,
Stay
can
up
you
on top
can you
of
hear me?
things.
Prof, we can hear you. I think they're trying to change the mic so that you can hear the question.
Come.
Hello?
Okay, it's no limit then.
Hey, good afternoon, can everybody hear me?
Try this one on my.
It was written too all the time. It's crazy.
Hey, good afternoon. Can you guys hear me?
Yeah, we can hear you now.
Okay. Right. The question that I had was with regards to the advancement of genetics and genomics and the molecular subclassification of the cancers such as breast and gastric cancer. If, and the fact that we, in Nigeria, you said that you guys present with more advanced cancers, and in Barbados, we have the same presentation. The question was asking, has there been any drives to molecularly subclassify these cancers all over the world to see if there are any geographical, ethnic, genetic, or cultural factors that may explain why more molecular subtype may be present versus in certain areas versus the others?
They heard it? Hello, panel, did you hear the question?
You guys were definitely cutting in and out.
Right, so
I think
we
that's
were-
the problem.
so
We
Dr. Phillips
did,
was-
but again,
Right, he was asking about
it definitely
genetics.
cut out. I can offer a quick, yeah.
Right, he was
I
asking.
can summarize. Prof. Alatishe, I think they're asking about whether or not there's been work to categorize perhaps geographic variability in gastric, breast, colon cancer.
Right, specifically colon cancer and the relationship between any genetic mutations or subtypes and how that relates to ethnic or geographic factors.
Of the MSI, predominantly, I guess.
So, for example, was there
Not
any?
related to the MSI specifically.
MSI and
Yeah,
Because you were saying that the MSI, you were seeing more MSI on the left, but was there any further, subtyping going on in terms of other genetic mutations, or any link between genetic mutations and a geographic area or ethnicity?
Yeah, thank you. Can you hear me, please?
Yes, we hear you.
Yep, I can hear you.
Yeah, so thank you for the question. That is an interesting one. Definitely, there has been some regional peculiarity when it comes to breast, gastric, and colorectal cancer. Just like we described, we have MI in ditto to breast cancer. It has been shown by multiple groups that triple negative breast cancer is about 40% of the total breast cancer cases that we see. If you look at the literature from the Western country, they will be talking about triple negative less than 20%. So definitely some regional peculiarity to the occurrence of as regard to
I think so.
have been evaluated at the and that's why we are some other group to be able, and with also Roche to be able to do some genomic atlas and characterizing some regional peculiarities to colorectal cancer and breast cancer. currently we are doing about whole genome sequencing of about 250 colorectal cancer. And from that study, what we hope to do is to be able to reclassify colorectal cancer in Nigeria community using the current of see percentage CMS1, what percentage are CMS2, what percentage are CMS3 and CMS4, just as has been described for other regions. That data will not be ready until the end of the year. Then we'll be able to talk more about the funded, and the sample is already getting to the lab, and hopefully we'll be able to have the data back and sub-classify, based on the available data from Genomic Atlas, we'll be able to sub-classify based on our data, what is the colorectal cancer sub-classification look like in Africa. A lot of work is still being done, and we are still not there yet.
Oh, thank you very much, Prof. That was very enlightening.
Dr. Griffith, can I make a comment?
Please do.
One of that question is really exciting.
Yes.
And I think that if there's one, can you hear me okay?
You're breaking a note, but yeah, please.
Yes, we can hear you.
I just wanted to say that I think that question is really the future of some of the next breakthroughs in cancer research.
Yes.
Prof. Alatishe mentioned it. And it to me, as someone who treats a lot of breast cancer and colon cancer, it's one of the great remaining of many, but one of the great unknowns or mysteries that remains, which is why do African American women in US and Canada and have such a high rate of triple negative breast cancer, and why does it seem that there's also a very similar high rate of triple negative breast cancer in Nigeria, in West Africa? Yeah. And to me, and I'm not a scientist, most African Americans are West African heritage, yes, and they share all they share in common is their ancestry, but there are very different risk factors between the two populations.
True.
And there's something that links it genetically that has nothing to do with environment or modifiable risk factors, True. In my opinion. And we don't have an answer to that question. It's like one of the big unknowns.
It is truly.
And I think that when we understand better why African Americans or West Africans or Nigerians and maybe in Barbados have a higher rate of triple negative breast cancer, we'll have a better, much better understanding of how to prevent it. That's unique to that patient population.
I'm gonna. This is.
I have a theory.
This is very interesting, and I'm gonna make a comment before we come to the end. I want to big up at this moment. This is a key discussion. I want to big up Dr. Jason Copeland and the group at the Kingston Public Hospital with the Jamaican Breast Registry. They're breast surgeon. They're doing a database over there. What they have found, for example, if we're going to tie this together, in some preliminary stuff, they haven't published it yet, but what they're finding, for example, is that when the international data says, and I am not a breast surgeon, so to me to talk about breast, I had to read this recently. So at this point, what they're finding now is that whilst the international data is suggesting that for early low-risk breast cancer, there is no reason to do the CTs of the chest, abdomen, and pelvis, along with the bone scan. What they are finding is that in the data group out of Jamaica, that they're in early low-risk breast cancer, they're seeing higher levels of positivity with regards to nodules in the lungs, on the CT, and in the liver, and so in the abdominal. They're not seeing much benefit in doing the pelvic CTs or the bone scans, but those two things are necessary. And why I'm saying that is we from this diaspora unit need to come up with, along with those from the from West Africa itself with some guidelines for ourselves. Because in our groups, it seems as though from this early preliminary data that even in persons in women with low risk breast cancer, they might be benefiting doing CT chest and CT abdomen at least in that particular patient group, whilst the international guidelines are saying no, which ties right back with Prof. Aleticia's point that he made earlier. Now, I want to thank you again. I want to thank everybody who came out, the public, the surgical group, the non-surgical group, all the medical personnel, the nursing. I would like to thank at this moment the Caribbean Colon Cancer Initiative admin, the group again, the 2 junior fellows in the group, Dr. Anissa Thompson and Dr. Brandon Griffiths. And at this point in time, I want to allow Dr. Thompson to come and give the closing remarks. I want to thank everybody that was online. I want to thank the groups that have contributed, the Barbados National Registry, etc. So, Dr. Thompson, over to you for the closing remarks.
Esteemed panelists, colleagues, and members of the wider community, good evening. As we bring today's conversation to a close, I'd like to take a moment to express our heartfelt gratitude to each of you, the panelists and the audience, both here in person and online. What we've engaged in today is far more than a panel discussion, but it has been a necessary and evolving conversation about the future of colorectal cancer care in Barbados and across the Caribbean. The themes we've explored, from the accessibility and urgency of screening to the relevance of ancestral genetics and the preventative potential of diet, all speak to one clear truth. The future of colorectal cancer care in our region must be both evidence-driven and culturally attuned. The insights here today remind us that advancing colorectal cancer care requires more than clinical expertise. It demands innovation, yes, but also culturally informed research, sustained public education, and above all, collaboration across disciplines, across institutions, and across borders. To that end, today's dialogue represents a vital step toward a collective response that is research-driven, community-informed, and globally connected. Let this not be the end of the conversation, but the beginning of a renewed commitment to act, to advocate, and to align science with equity. Let us carry this momentum forward with urgency, with compassion, and with the clear understanding that this is only the beginning. Thank you.
I have the mic off.